on time. Show. Oh, I think that's so funny. Can you hear me now? Hold on. All right, cool. All right. I don't think I posted it, but today we are focusing on pharmacology. Let me see. Let's see. Pharmacology, MSK interventions, and postural drainage. So, hopefully that's super exciting for you. Okay. Hey, before we get started though, I'm going to put my dogs away real quick. Come on, guys. Go inside. Good job. Okay. I am ready. How are you a Bruins family in Arkansas? That's a good question. In 2011, Arkansas, we didn't really get hockey on like network television around here for a really long time. And then in 2011, I was a junior in high school, and um, the Bruins were playing. I don't remember who it was, but it was the first round of the playoffs. And the Bruins, it was like game 3 or game 4, and they ended up winning with like 30 seconds left in overtime. And I was like, that was a sick win. And so I just kept up with them all throughout the playoffs. It was the first time I really got to watch hockey other than like Mighty Ducks. And so I followed them, and then they won in 2011. And so I decided I was going to become a fan. And wouldn't you know it, as soon as I decided to become a fan, they haven't won another Stanley Cup. So can't really explain it. Fortunately, I picked a good team because my father-in-law is from Springfield, Massachusetts, so we get to talk about it all the time. All right, we're going to go ahead and jump into the questions tonight. Again, if you guys are just tuning in, we are going to go over pharmacology, MSK interventions, and postural drainage this week. I have some more topics. I'll go ahead and let you guys take a look, especially you, user. I know that you contributed some to this, I believe, a few weeks back. The next set of questions was going to be regarding cranial nerves, pediatric milestones and reflexes, and lymphatics. And then, like, you can kind of see what the next 3 weeks would be like: non-systems, differential diagnoses, neuro. Someone asked specifically for SCI. Then we got prosthetics, metabolic respiratory acidosis, alkalosis. I'll probably just make that. Do I share these documents? No, I do not. These are mine that I've created myself. But I do post these lives on my YouTube channel. And then, so someone asked specifically for SCI. I'll probably do a mix of intervention and examination with this. And then with this one, I'm probably going to do more just like complex medical stuff, because I feel like it's not senseless to do 5 questions necessarily in metabolic or respiratory acidosis and alkalosis, but once you figure out the way to determine which one it is, it's just repetition. And so I don't feel like we need to spend a ton of time on just that topic when we could cover complex medical stuff. How many weeks do you recommend preparing for the NPTE? I studied for way too long. I studied for like I shouldn't say I studied for 16 weeks. I studied with 16 weeks left until my boards. And after like week 12 or 13, I was so fried that I was like just studying to maintain. Do I think 6 to 8 weeks is too short? Not necessarily. It depends on how prepared you already are right now, and how much room you feel like you need to grow to get that passing grade. Maybe you're already feeling good, like you can pass. But like when I got back to PT school after my last rotation, I took our first Pete, that practice form, and I got, I want to say like a 630 or 640. And so I passed that one, felt pretty good, but I still had a lot of like spots that I needed to tweak. And then, so I spent a ton of time studying that stuff. If you guys want to, we're just getting started. If you have classmates or friends in PT school that you know would be interested in going over some practice questions tonight, feel free to share my live. I just wanted to touch on this so that way you guys get an idea of what the next few weeks are going to hold in store. I'll try to do a better job um, posting some like little photos or something that tell you in the weeks to come what the next topics are going to be. This is action, origin, innervation. Hold on. Action, origin, insertion, nerve, and I don't remember what the S stands for, but someone asked me to put that on there. Okay, so tonight we will start with pharmacology. I take my PEDS exam in less than 2 weeks and have been in clinicals for the last 8 weeks. Yeah, I didn't study while I was on my last clinical. If your first PET is like the practice form where it's just like taking it, then don't worry too much about that because at least the way my PT school was set up is you didn't have to pass the first practice form. You had to pass the retired form later on. Okay, user's pushing me to make sure I stay on task because it's already late where he's at. A patient with Parkinson's disease is taking carbidopa-levodopa. During therapy, the patient suddenly develops involuntary writhing movements of the trunk and extremities. What is the most likely explanation? A. Medication-induced medication-induced dyskinesia. B. Progression of Parkinson's disease. C. Acute cerebellar stroke. Or D. Peripheral neuropathy. You guys go ahead and submit your answers. I always encourage you guys to interact because the more you interact with the material, the more that it's going to stick in your brain, even if you get it wrong. While you guys are answering, I'm going to see if there was another question. Thank you, Solus. It was good to see you. Studied for 6 months because I'm working full time, but had to leave 3 weeks to focus. Yeah, no kidding. It's 2 weeks. Honestly, if it's your first PET that you're taking, though, like I wouldn't stress too much about it if it's not the one you have to pass to graduate, right? I wouldn't stress too much about it because it's going to be a good baseline to tell you, like, well, what are my weakest areas, and that'll help you develop your study plan in terms of like what's the stuff you want to hit first, and then what's the stuff that maybe you don't need to study as much because you already know it pretty well. Looks like most of you guys got this right. The answer is A. It's incredibly common. With carbidopa-levodopa, especially in chronic use, that your on time gets shorter and then you end up above that threshold of on time and it's not off time anymore. You're actually over on time where you're getting these dyskinesias that are actually precipitated by the carbidopa-levodopa. We take 2 practice PETs and have to pass 1 of them. I have 2 free ones I want and we'll take it tomorrow. I think you're going to be fine then. I mean, as long as like if you study or if you have till May to pass one of the PETs, then I would just take one. If you pass it, awesome. That means that you don't have to pass the other one, right? But if you don't pass it, don't stress about it. You've got plenty of time. There is on-off phenomenon, right? So you take the carbidopa-levodopa. It takes about half an hour to an hour to kick in to where you're going to be on your on time. In the early stages of Parkinson, or sorry, I shouldn't say that. In the early stages of being exposed to carbidopa-levodopa, you're going to see this curve where there's like this threshold. Your off time is down here. You're going to take it. You're going to hit about 60 minutes later. You're going to be in that on time. And then you have the top portion of the threshold. And in the early stages of taking carbidopa-levodopa, it never transcends that upper end of that threshold, right? So your on time is really long, okay? But the more you take it, it ends up going above that top threshold, and then your on time is a little bit, it's going to be reduced because then you're in this dyskinesia zone until it starts tapering down and it hits its half-lives, right? And then you're in on time again, and then as you get lower, hey, Bruins, yeah. They lost tonight, and I was pretty upset about it. But once you get back below that top threshold, you're going to be on time again, your dyskinesias are going to disappear, and then obviously hit your off time again. So that's what happens there. But good job there. Honestly, the only one that might have been tricky is acute cerebellar stroke. You're not going to see in time progression of Parkinson's disease. That would be absolutely wild. If I suddenly saw them get this like way over exaggerated sense of like greater Parkinsonism, I would be much more concerned about something crazy like an infarct happening in real time to the basal ganglia, right? But acute cerebellar stroke, you're seeing some writhing movements, which could be considered like ataxic or athetoid, right? Which could be a cerebellar thing. But honestly, you got the carbidopa levodopa that you know is going on, it's way more likely that they're just getting that medication induced dyskinesia. Go Panthers! No, I only root for Matthew Tkachuk when he was playing for USA, but now he's my enemy again. Okay, number 2. A patient taking a beta blocker such as metoprolol is participating in aerobic exercise training. Which physiologic response should the therapist expect? A. Increased systolic blood pressure. B. Increased heart rate variability during exercise. C. Reduced maximal heart rate. Or D. Enhanced sympathetic activation. Go ahead and submit your answer choices, and I'll give you guys some time. While you guys are doing that, I'm going to run and grab myself a bottle of water real quick, but read over it again if you need to. Submit your answer choices. All right. Take a look. Looks like many of you guys are locking in answer C, so let's take a look at it. You guys are right. The answer is C. So all of the other answer choices are actually like the exact opposite of what you would expect to see, right? So like beta blockers are gonna inhibit maximal heart rate, which means they're also going to reduce heart rate variability because it's not going to get up as high above resting heart rate as normal. Cardio is my ish. You know this, Austin. I know, dude. I know. Can't remember the name of that dude that you would always piggyback off of when it was something that was tough. It was several weeks ago, but he like locked in really hard on. I want to say it was like MSK or something, maybe something totally random. Enhanced sympathetic activation. You actually don't see enhanced sympathetic activation. That's why you use beta blockers, because this is going to inhibit things like AFib, right? Which is like uh, potentially triggered by exacerbations of the sympathetic nervous system. So you want to keep that under control with beta blockers. Beta blockers, in fact, are actually used as PRN anxiety medications too, as well, which I always think is really interesting. And so it's actually going to hamper your sympathetic response a little bit. And then you may or may not see an increase, like a substantial increase in systolic blood pressure. Again, it's kind of decreasing that firing rate of your sympathetic nervous system in order to manage your cardiac condition. So, all right, moving on to number 3. A patient taking furosemide, also known as Lasix, for heart failure complains of muscle cramping and fatigue during therapy. Which electrolyte imbalance is most likely responsible? A. Hyperkalemia. B. Hypernatremia. C. Hypocalcemia. Or D. Hypokalemia. Propranolol is common for anxiety. Yes, yeah, I had a boss. I used to work in college ministry, and I had a boss who, funnily enough, like she was a pastor, and she was really scared of public speaking unless she was in her element. So um, she was fine giving sermons like in front of college students, but as soon as she had to give sermons in front of like a church full of non-college students, she would get really bad anxiety. So she was prescribed propranolol for anxiety. Can't wait to hear you talk about these. Sure. All right, give you guys a little bit longer. Okay. I know what they are for. I know what they are for. It's just more so one causes which. So let's talk about it. Okay. So muscle cramping and fatigue during therapy, that means that one of your electrolyte, like we should know this, right? The reason we drink Gatorade when we're playing sports, the reason that people tell you to drink pickle juice, the reason people tell you to eat bananas, right, is because um, if you are low on electrolytes, it's going to produce cramping, right, and fatigue because you don't have enough electrolytes to help establish healthy muscular contraction, and so it's going to end up causing um, things like muscle cramping and fatigue. So if you know that cramping is a result of being low on electrolytes, then you should be able to rule out A and B, right? So then we come back to hypocalcemia. So hypocalcemia may lead to fatigue, but it's not going to lead to the same kind of muscle cramping because you don't use calcium in the same way during muscular contraction as you use potassium. So hypokalemia is more likely to cause muscle cramping. I will say though, if this said hyponatremia, that would be tough because in terms of like what's happening at the sliding filament level and at the neuromuscular junction, you need sodium and potassium to be able to sustain good tetanic contraction. And so if you are low on potassium or sodium, it can cause that muscle cramping and fatigue. So I wouldn't have created this saying hyponatremia and hypokalemia. I would pick one or the other because honestly, that's too tricky to be able to distinguish between. One thing too about these two, obviously if you're hypernatremic, that means that you're probably hanging on to a lot of water, right? And so Lasix particularly is going to like flush out a lot of fluids, which means you probably aren't going to have a lot of sodium or potassium in your like you're not going to be excessively natremic or kalemic because um, your body's trying to keep that equilibrium, right? So the more fluid I drain off of me, I'm also peeing out more of my electrolytes. And so that's another reason why if you're on Lasix, you're probably not in a hyperkalemic or hypernatremic or hypercalcemic state, right? Does that all make sense? Is anyone annoyed with me for that one? Yeah. Hyperkalemia is also can cause potential for cardiac arrhythmias as well. So if someone is hyperkalemic, uh, I don't really ever know this because I'm in the outpatient setting, but if you're in the hospital setting and they're checking labs normally, if they're hyperkalemic, you got to be worried about cardiac. It's when they start Harlem shaking. Yes, that's a good way to put it, I guess. Maybe don't say that to your patient unless you know them really well. I didn't even reveal the answer choice. Hypokalemia is the correct answer. Yeah, it would be a big deal if someone was already taking Lasix and they were still hyperkalemic, because that means that this is not effectively getting fluid off of their body, because once it takes the fluid off, it should also take some of your electrolytes out as well. But you're right. We probably need some potassium sparing diuretics at this point, because if they're hypokalemic on Lasix, then we need to get the docs to switch them to a different potassium sparing diuretic so that way they don't run the risk of that. Okay, number 4. A patient taking levothyroxine for hypothyroidism receives an excessive dosage. Which clinical finding would most likely occur? A. Bradycardia. B. Heat intolerance. C. Weight gain. D. Cold intolerance. I'll give you guys some time to think about it and look. We'll talk through it here in just a second. Not many people answering this one. I'm going to wait until someone submits an answer. We only got 2 more of these, guys. We only got 2 more of the medication ones after. Oh, well, no, we got this one and one more medication one. And then we'll get into MSK interventions, which is like everyone's bread and butter, right? What's your advice on these? Because I sort of struggle with these. So I would look at, they're only going to ask you about so many medications, right? Because there's only so many medications we need to know about that's going to affect, not ANC, I'm overthinking the temp. Hey, sweet pea. So, and honestly, you don't have to know that much about even levothyroxine, right? You don't need to know about the mechanism of action or like what it's doing inside of the blood or how it's, generally it's probably good to know like how it helps people with hypothyroidism, right? And so, generally speaking, levothyroxine is introducing artificial uh, uh, thyroid hormone, or T3, T4. But basically, hypothyroidism, their thyroid isn't producing the hormones effectively. Levothyroxine helps take people out of hypothyroidism. So the reason that this might be a tough question is if you aren't thinking, if you just get stuck on and locked in on hypothyroidism, well, what are the signs of hypothyroidism, right? And so we think like you're going to have decreased sympathetic response, right? So we're looking more like bradycardia, weight gain, cold intolerance, whereas hyperthyroidism is where you're going to have that heat intolerance, you're going to have weight loss, um, you might have things like trouble sleeping and things like that. Everything, yeah, with hypothyroidism, everything slows, right? And so, including your metabolism. And so, what this question is asking is the person has hypothyroidism. They're already taking levothyroxine to combat that, right? They're saying they got an excessive dose of this, which combats this, right? So, basically, what they're saying is they're having medication induced hyperthyroidism. And so, we know that if they're having medication-induced hyperthyroidism, they're not going to be bradycardic because that would be if they like miss their medication for their hypothyroidism, right? Same thing with weight gain. Of course, that would take time. That wouldn't just happen like right away. And again, if they miss their levothyroxine, and then cold intolerance is a sign of hypothyroidism. So they either miss their levothyroxine dose or the levothyroxine is not working the way it's supposed to. So they're saying they OD'd, OD'd, got too much levothyroxine, which put them into medication-induced hyperthyroidism, which would lead to more likely heat intolerance than any of the rest of these three. But it could be any signs of hyperthyroidism that would happen there. Okay. All right, number 5, last medication. But to answer your question, user, because I didn't really answer that, did I? The big ones for cardiac that you need to know generally like your ACE inhibitors. You need like what's the mechanism of action of your ACE inhibitors, of your angiotensin 2 receptor blockers, of your beta blockers for sure, because that's going to impact exercise 100%. For pulmonary stuff, really you need to know like the effect of different bronchodilating medications and like what's a good time frame uh, before which to take it, right? So like a rescue inhaler versus like something that they're supposed to take regularly. I'm trying to think if there's anything else with cardiac. You need to know the stuff about lab values because if they're hyper or hypokalemic, you need to know how that would affect their cardiovascular system. You also need to know how that would affect their muscular system. 4 so far. I'd just be unsure with my answer. Which leads to overthinking and then get the answer wrong. Yeah, for sure. And then for neurology, the neurologic section, I would know, Amelia, stay out of the camera, sweet pea. Stay out of the camera. You need to know your muscle relaxers, like your antispasmodics for sure. You need to know the effect of carbidopa, levodopa. I think what else you definitely need to know about TPA, right? And like that emergent window when someone would get TPA if they were having a stroke, if they were having a ischemic stroke, obviously not a hemorrhagic stroke. And then things like you need to know the effect of long-term use of corticosteroids or lack of cortisol, things like that. Yeah, it's a lot, but I feel like I'm just kind of rambling at this point. Number 5, a patient receiving systemic antibiotics for an infected wound develops diarrhea and abdominal cramping after several days of treatment. Which complication should the therapist suspect? A. Allergic dermatitis. B. Clostridioides difficile infection. C. Diff infection. C. Drug-induced neuropathy. Or D. Iron deficiency anemia. Go ahead and take some time to answer the question. 5 out of 5 loading. Very confident. I also just want to point out, if you guys are like, well, I don't know why I get so many of your questions right, and I'm going to take practice tests, I feel like I struggle. 2 things. One, if I'm not writing hard enough questions, you guys need to tell me because I only do this for the sake of helping you guys, right? So if they're not challenging you adequately, then I need to know. Number 2, The thing that could make it different is that I am reading it for you, right? You are not having to read it. And so when you are taking a test, if you're reading particularly quickly, you may misread something or miss a key word in the question, right? It's different when you're hearing me read it, right? Because you can pick up on all the stuff. Sometimes you may just read too quickly over stuff. So, okay, we're going to go ahead and talk about this one. The answer is B. So when you're taking systemic antibiotics, it's going to kill your good gut bacteria. And when your good gut bacteria dies, C. diff has nothing to compete with, and so it can populate, right? They tend to be resistant to a lot of antibiotics. So when your gut bacteria are not resistant to these systemic antibiotics, that C. diff will thrive. And so then you get symptoms of diarrhea and abdominal cramping, right? Okay. Number 6, we are jumping into MSK interventions. A patient is 2 weeks post supraspinatus repair and is currently in a shoulder immobilizer. Which intervention is most appropriate? A. Active shoulder abduction to 90. B. Resistive external rotation strengthening. C. Passive shoulder flexion within surgeon guidelines. Or D. Closed chain weight bearing through the arm. All right, user. Work on your clean sweep. Hey, Gentry, it's good to see you, dude. 6 out of 6 coming out. Okay. We'll give you guys just a few more seconds to see if anyone else is going to submit. Okay, let's go over it. All right. So the answer is C. Early rotator cuff rehab is going to focus, especially in the first several weeks, you're going to be focused on passive range of motion to prevent stiffness while protecting the surgical site and the muscles that are under repair, right? So if you do active movement at all, it's going to recruit the repaired muscle and risk repair failure or tearing of the site, right? Resisted external rotation, same thing. It's going to be too aggressive at 2 weeks out. You want to protect all of that. You said 15, and I've actually got 16. But that's just because I wanted this. Someone specifically asked for a piriformis syndrome question. I don't even know that they're on here tonight. I've got a pretty low count tonight, which is whatever. But so I've actually got 6 MSK questions and then 5 of my postural drainage questions at the end. Okay, and then D, weight bearing is going to cause significant rotator cuff activation, even if it's isometric. Isometric is still going to be too aggressive in the beginning, and so the answer is C, passive shoulder flexion within surgeon guidelines. We just got to keep it loose and moving, right? So that way we protect that muscle tissue. Number 7, a patient with lumbar lateral spinal stenosis reports decreased symptoms when leaning forward on a shopping cart. Which intervention is most appropriate? A, flexion-biased exercise program. B, lumbar traction and extension. C, prone press-ups. Or D, lumbar extension exercises. This one shouldn't be that tough, right? Yeah. You know what the diagnosis is. They already told you what makes them feel better, so you should be able to get this. Right, Sweet Pea? Yeah. Okay, we'll go ahead and go over the question. Okay, the answer obviously is A, lumbar flexion increases the foramen diameter, which is going to reduce symptoms of stenosis. Extension positions would likely worsen symptoms, even if you're giving lumbar traction. Your in-net extension was going to worsen symptoms. Prone press-ups increase lumbar extension, and the lumbar extension exercises extension narrows the spinal foramina. So all of those are bad answers. Number 8, a patient is 4 weeks post ACL reconstruction with a hamstring graft. Which intervention should be avoided? A, quad sets. B, stationary cycling. C, resisted hamstring curls. Or D, closed chain mini squats. To be fair, Austin, this is my 3rd attempt, so I'm just very familiar with concepts. That's true, dude. Yeah, that's my daughter in the background. We have been having a hard time getting her to take naps recently. At school, she normally goes down like late morning, early afternoon. But when she's here at home, she doesn't want to go to bed at that time. So today we just pushed through to see if we could get her to not take a nap, and she fell asleep at 5 o'clock, and her bedtime 7:30. So she's up because she slept for like an hour and a half. Yeah, so you're up late tonight. I know, dude. No kid wants naps. It's okay. Okay, let's go over. You guys nailed it. Of course, you might have to. Amelia, you need to go, sweetheart. You can hang out in the room, but you can't touch this stuff, okay? Close call. Um, you probably would need to be careful with. Thanks, Louise. You probably need to be careful with stationary cycling, just making sure that you're not setting too much resistance against it, because when you cycle through, right, and you're coming up into hip flexion, you're also coming into active knee flexion. Yeah, that happens. But really the most aggressive thing here that you definitely want to avoid is that resisted hamstring curls. You have to protect the site where the graft came from. Um, Obviously, if you take from the hamstring, you have a smaller tendon, right? So that thing is still in repair. You need it to scar down as well. And so if you do resisted hamstring curls too early, you risk damaging the remaining tendon. Quad sets are actually really important. You need to get early quad activation um, happening. B, cycling is going to promote range of motion and circulation. Again, just be cognizant about how much resistance you're putting it through. But anytime anyone is after uh, any kind of knee surgery, you see them getting on the bike, right? Because you need to promote as much flexion as possible actively. And then you can even do it passively with the strong side. And then closed chain exercises are safe. You know, it's mini squats, so you're not getting into that depth where you got to be concerned about the integrity of the graft inside of the knee. And so that one, I mean, they do that all the time. And 4 weeks is not too early by any means to be introducing those. Number 9. A patient with mid-portion Achilles tendinopathy is beginning rehabilitation. Which intervention has the strongest evidence for improving outcomes? A. Immobilization in a walking boot. B. Eccentric heel drop exercises. C. Ultrasound. Or D. Passive calf stretching. Good job. Many of you are jumping right on this one. Okay. It may not take long to get through all these tonight. We're kind of cruising because you guys are killing it. If any questions come up, let me know. Okay, so the Alfredson eccentric protocol is strongly supported for Achilles tendinopathy. If you weren't sure where the recommendations for eccentrics with tendinopathies, particularly tendinosis, right, but tendinitis as well, Alfredson eccentric protocol. If you haven't looked it up in PT school, look it up, especially if you're planning on being in orthopedics. I am not, so I have not read this thing in a long time. But eccentric heel drops are actually really good for loading the tendons without stressing them too much. Immobilization is gonna, I mean, ultimately, it's probably gonna worsen your tendon capacity because you're not utilizing the elasticity of those fibers, and you need to retrain them to do that elastic work. C, ultrasound has limited evidence with everything, and D, stretching alone does not address tendon loading adaptation. So I can have them I can passively stretch their calves, right? But I can't put the same sort of force that their body is going to put on those tendons. So while this might be helpful, it's not going to be better or most strongly uh, evident as eccentric heel drop exercises. Make sense? Everyone good with it? Cool. Number 10, a patient with lateral epicondylitis reports pain with gripping. Which intervention targets the most relevant impairment? A. Wrist extensor eccentric strengthening. B. Finger flexor stretching. C. Bicep strengthening. Or D. Passive elbow mobilization. right, you guys are absolutely correct. Wrist extensor eccentric strengthening. So we just talked about the responsive tendons to eccentric strengthening, right? Lateral epicondylitis is an issue with the common uh, extensor tendon of the forearm, right? And so eccentric is going to be best. Finger flexor strengthening um, is not a primary pathology. Now, you may develop issues with finger flexors secondarily, right? Because you're having to utilize them more than uh, you would normally because your wrist extensors are painful in like grip strength, right? But this is not going to help uh, the tendonitis. Bicep strengthening, not even involved in wrist extensors, right, or grip strength. And D, elbow joint mobility is usually not the issue, right? So easy peasy lemon squeezy for that. Okay, here is our piriformis question. A 38-year-old runner presents with deep buttock pain radiating down the posterior thigh that worsens with prolonged sitting and running uphill. Lumbar screening is negative for radiculopathy. Palpation reveals tenderness over the piriformis muscle, and symptoms increase with hip internal rotation inflection, or the Fader test. Which of the following interventions would be most appropriate early in the rehab program? A. Aggressive lumbar extension exercises. B. Piriformis stretching and hip external rotator soft tissue mobilization. C. Heavy resisted hip external rotation strengthening. Or D. Prolonged bed rest and activity restriction. Just checking to see if I missed any questions. No. Okay. Good job, guys. Okay. 5 to go. Looking good. Might even finish before 10 tonight, hopefully. All right. B is the right answer, right? So piriformis syndrome typically involves your sciatic nerve being irritated, which is caused by that piriformis compression or hypertonicity, right? So we need to focus on decreasing the tension or the tone of that piriformis muscle so that way we can decrease the pressure on the sciatic nerve. We also need to improve hip mobility generally. And so soft tissue mobilization to your hip external rotators can help loosen everything up, which means you get less compression on that sciatic nerve, right? A is going to target lumbar disc pathology, not piriformis. C, the piri is already overacted and irritated, so early strengthening may increase compression on the sciatic nerve. Obviously, later on in their rehab, you probably want to help strengthen the other external rotators, right? Not just piriformis. And so, sorry, I lost my train of thought, brain fart. But this is not going to be the most important thing early on, right? And then D, evidence strongly supports early controlled movement for MSK conditions, right? Prolonged bed rest in MSK conditions is probably never going to be the issue unless they like broke their leg and they're non-weight bearing. But it's not going to be bed rest. Have to be pretty crazy injury to go on bed rest for an MSK thing. All right, number 12, we're jumping into postural drainage. A patient requires postural drainage of the right lower lobe posterior basal segment. Which position is most appropriate? A, prone with the foot of the bed elevated. B, supine with the foot of the bed elevated. C, sitting, leaning forward. Or D, left side lying flat, meaning like no elevation, no D elevation. Just checking to see how many of you guys answer so I can keep track of when I can go ahead and go over the answers. 6. Okay. Give you guys a little bit longer in case anyone else. I had to make sure I didn't overread this. Okay. I think that may be everyone that answers, so let's go ahead and jump right back in. So the answer is A. So the lower lobe posterior basal segment is going to require the patient to be prone with head down. B is going to target your anterior basal segments. C, leaning forward, drains upper lobe, posterior segments. And then D, side lying without head down tilt will not effectively drain the posterior basal segment. So if it was, I mean, you might get a little bit on side lying if they're like foot of the bed is elevated, but you're not really isolating the posterior basal segment, right? You're more getting the lateral segments. Number 13, a patient with severe GERD requires airway clearance therapy. Which postural drainage modification is most appropriate? A, increase percussion intensity. B, add Trendelenburg positioning. C, avoid head down positions. Or D, use prolonged prone positioning. Have you been studying postural drainage, user? Honestly, when I got to postural drainage, it was literally just a chart that I made, and I just memorized all the segments and what position you'd need to be in. Honestly, once you know your anatomy, it becomes pretty easy. Cardio is just my ish. Say no to reflex. Are you going to be a cardiopulm specialist then, user? Working acute? Or cardio? Well, we don't really get to work in cardiac rehab. It's usually just exercise physiologists. But we need more cardiopulm therapists because there's not enough of them. Especially if you want to get into teaching, because there's like hardly any people that go into teaching that are cardiopulm therapists, and it's the hardest position to fill, from what I've heard. I'm a neurotherapist, so we're a dime a dozen, I guess. All right. So, avoiding head down movements, right? Because if their head is down, if their head is my hand, right, and they go like this, you're getting all of that, like, gravity is pulling the acid from your stomach up your esophagus if your head is down, right? So we don't want to do it. Might as well, both my rotations, we're working with CVICU patients in limb. Do it, dude. That'd be fun. Especially if it's like complex ICU stuff, right? Like trauma. Increasing percussion isn't going to change anything. It's not going to address the reflux. B, Trendelenburg would be the opposite of what we said the answer was, and then prone positioning isn't going to solve reflux either. Okay, number 14, we just got 3 left. Which position is used to drain the left upper lobe lingula? A, right side lying with head tilt down. B, supine with head down tilted and body rotated a quarter turn to the right. C, prone with bed flat. Or D, left side lying with head down tilt. Most of my patients with GERD will tell you straight up not to lay them flat, so I can't forget. Yeah, I've got a patient, this poor guy. He had a hiatal hernia, and so he gets a lot of reflux. And and he's got CP, so he's got really bad tone. And sometimes I'll spend some time stretching him out. And like the first time I did it, he had some pretty bad reflux because I put him to like I had a wedge behind him, but it wasn't steep enough, and so he ended up having some bad reflux. And never made that mistake again. Only make that mistake once. Just a handful of you guys have answered. We'll wait a little bit longer, see if anyone else wants to answer this one. Being here makes me feel like I'm in the middle of a lecture wearing a fake coat. Oh man, that's funny, Caleb. The bearded GM is a buddy of mine. We used to play D&D and Mutants and Masterminds together. He has a page where he's a GM now, and so Caleb in particular, I love your videos when you use that German accent and you're like dogging on people who have like tried to roast you in your comments. I bust up every single time I see those videos. Your German accent is just so good. And especially when you're talking, and it's just like you hit words that I'm like, it doesn't sound like you have to think about it at all. Kleist von Kleist. Okay, let's go over the answer choices. So the answer is B. The lingula is drained with patient in supine and rotated slightly to the opposite side with Trendelenburg, right? So A is going to drain the lower lobe lateral segments. C is going to target posterior lung segments, right? And then D would compress the left upper lobe lingula rather than drain it, and so that would not be effective, right? So if you think about it, you're going to be supine quarter turn to the right, so your left upper lobe lingula, which is like here, right? Left upper lobe lingula. And so if I'm a little bit head down tilted, body quarter turn, it's going to get right into that bronchiole that drains into the main bronchus, right? And then I'm going to be able to cough that up. Well, obviously, it's the lingula. These ones are tough, okay? Postural drainage is not fun, but if you just go over them, like look up in your textbook or in your school builder's book or whatever study book you're using, because there should be a chart or like a whole section that tells you if it's this segment, this is the position you want them in. So, number 15. During postural drainage treatment, a patient suddenly develops increased dyspnea and oxygen desaturation. What is the therapist's most appropriate immediate action? A. Increase percussion intensity. B. Continue treatment for secretion mobilization. C. Return the patient to an upright position. Or D. Add vibration. Give you guys some time. Since we're about to get done with this question and the last question, and I'll have a little bit extra time at the end, or if you guys have any questions specifically about content in general, or you want me to add to my topics to cover, I'd be happy to. My individual and uninfluenced answer. C. Yes. Oh, yes. Okay. All right. So, if respiratory distress occurs when you get the patient into your postural drainage position, the best thing you should do is stop doing what you're doing and get them back to upright, right? That's not a tough question. You're getting increased dyspnea and oxygen desaturation, you want to get them upright immediately, right? A is going to worsen their distress. B, continuing treatment is unsafe because it could worsen their dyspnea, it could worsen their desaturation. And then D, vibration is not going to address acute hypoxia. So, dude, you're nearing 6K followers. I know, I'm working on it. I would say I've been lazy, but I haven't been lazy. Things are just super busy now. That I haven't been making like videos as much. I've really just been relying on my lives. So, unfortunately. Okay, number 16. Which postural drainage positioning is most appropriate for the apical segments of the upper lobes? A, sitting upright, leaning back slightly. B, supine with head down tilt. C, prone with head down tilt. Or D, right side lying with bed elevated. A little bit longer. Just a handful of people left yet to answer. Okay. All right. Very good. The answer is A, right? So the apical segments are going to drain best when your patient is upright. So if they're the posterior apical segments, they're going to be leaning forward. If the anterior apical segments, they're going to be leaning backward a little bit. But because of the orientation of them, the bronchioles that actually go up to the apical segments are like shaped like that, right? Let me do the finger here. Like that. And so if the apical segments are going to drain, they need to drain down first into the main bronchus and then cough it up. I thought it was leaning forward, not backward. That's what got me. So if you're getting posterior apical, I guess I was a little bit unclear with that, Gentry, and that might have been my bad. What did you say? Let me see. C, huh? Prone with head down tilt. If you did C, prone with head down tilt, like I said, because the way that those bronchioles are oriented, if you use C, then you're not going to get the fluid into the bronchiole to get to the main bronchus to cough up. And so, yeah, it's leaning forward for posterior apical. Maybe I should have been a little bit clearer about which portion of the apical segments were, but I will say, like, if you know that the apical segments they need to be sitting up, then if they only give you one sitting up answer, that's probably the one you should go with. Yeah, Rhea, you're right about that. Versus most others are supine or prone. Yeah, for sure. Or sideline or quarter turn, junk like that. But no big deal. You guys crushed it tonight. So that's all of the questions that I've got. Let me tell you one more time what we're going to do next week. I'm going to try to hit cranial nerves, pediatric milestones and reflexes, and then lymphatics. And then you can see what the next 6 are. So I basically try to cover 3 every week. This one is pretty general. Some people wanted more SCI related stuff, so I may do more like prognosis for SCI levels, complete levels, and then also neuro interventions, I think. Thank you, that's always awesome. Yeah, no problem, Gentry. User, good job getting all 16 right. Differential diagnosis, I'm not 100% sure how I'm going to split that up, but I probably will do that over all content areas. Non-systems is going to be more related to like ethics, role of the PT versus PTA, stuff like that, statistics. Prosthetics, that's self-explanatory. This I'm going to make more of like a complex medical, which is going to be more of like other systems basically. And then this is more related to musculoskeletal, knowing action origin, insertion, nerve supply. I think that's what the S stands for. Can you also give like referred pain pattern? Could you add some wheelchair components to the SCI like transfer level? Yeah, for sure. Yeah. So with the SCI stuff here in a couple weeks, I will go over specifically like how much would I expect a C5, a complete C5, to be able to rehab up to, and can you also give the referred pain patterns or something like Crohn's disease or renal? Yes, I can try to do that. Could you add ranchos and AIS scale questions, please? Yeah. Yeah. Let me see if I can find some, because I think on your boards now, they might give you sample Asias to have to interpret and then ask questions based on that. So I might try to see if I can find some practice Asias and we can talk through those as well. Go ahead and write out that pain referral pattern. Let me ask one thing, Rhea. When you say wheelchair components, what do you mean exactly? I hope you're still on here. What do you mean by wheelchair components? Because if you're talking like ADA stuff, then I probably would do that more in non-systems, like seat foot wheel. Okay, I'll do that more in non-systems because that'll be more like your ADA stuff and what you would expect measurements to look like, and like based on like how many finger breadths behind popliteal fold and yada yada yada. But I will add that on the non-system stuff. You guys have any questions about study habits or anything like that? Nope, I spelled that wrong. Here we go. Okay, and I think Rancho and AIS, and let's see, Vonnie asked for. You're right about that, level 4, 5, and 6, because those tend to be the big distinguishers. Like level 4 is agitated, confused, agitated, right? 5 is confused, inappropriate, and 6 is confused, appropriate, I believe. I'll have to review that, but I haven't seen it just in a bit. Referred pain patterns, yeah. Let me put that here too. Okay. So this will comprise like 7 through 16 is going to comprise like probably the next 3 weeks of classes. But yeah. All right, dudes. I'm going to go ahead and hop off of here. As always, feel free to direct message me throughout the week if you have questions about any content in particular, and I will post this up probably tomorrow or Tuesday on my Facebook. Yeah, no problem, Luis. Vonnie, it was good to see you guys. Rhea, thank you for being